A very warm good afternoon. So I would be discussing about the retinitis post-febrile illness with severe optic neuritis. So what we already know is that the post-febrile retinitis is very common in the tropical countries like India and mainly caused by viral or bacterial agents, and it can rarely be associated with optic neuritis. However, the patient presents to ophthalmic clinic generally 2 to 8 weeks after the onset of systemic symptoms. And the treatment aims at two modalities. One is to target the infectious organism and other to control the inflammatory reactions. So jumping to the case, our case was a 13-year-old male. He presented to OPD with the chief complaint of left eye loss of vision since 10 days. He had a positive history of fever 1 month ago lasting for 3 days. However, there was no history of any skin rash, joint pain, oral ulceration, cough, recent weight loss or travel to forest. The right eye visual acuity was normal. However, left eye visual acuity for distance was counting finger close to face and near visual acuity was less than N36. On torchlight examination, he had a grade 2 RAPD in the left eye. The external examination was grossly normal and anterior segment examination on slit lamp was also unremarkable in both eyes with intraocular pressure being 15 and 17 millimeters of mercury measured by Goldman applanation tonometry. The post-dilated examination of right eye was unremarkable. This is a colored fundus photo of left eye showing a medium-sized hyperemic disc with cup disc ratio 0.3:1 and a whitish fluffy retinitis lesion with vascular exudates along both superior and superior tempora and inferior tempora arcades with a curve of subretinal fluid and macular edema. However, this fundus finding does not correlate with the vision of counting finger close to face. So something else is still happening. This is a OCT picture of left eye showing a diffuse retinal thickening with the inner retinal layer hyperreflectivity and inflammatory hyperreflective dots. On the right of screen is a delayed phase fundus fluorescein angiography image showing retinitis lesion with central hypofluorescence and perilesional hyperfluorescence. So as we suspected something more than a fundus pathology, so we went ahead with the MRI, and as expected, he had a hyperintensity of optic nerve of both sides, that is bilateral retrobulbar optic neuritis, and on blood test he had a raised ESR with neutrophilia. However, the serology for infectious agents were negative. Rubella and CMV had IgG positive, but they have very less sensitivity. So a diagnosis of left eye retinitis post-febrile illness with bilateral retrobulbar optic neuritis was made. So the treatment was started covering the trial of steroid beginning with intravenous methylprednisolone 450 milligram for 5 days followed by tapering oral steroid starting from 35 milligram under the cover of empirical antimicrobial treatment of antiviral and antibacterials. So this is a daily clinical chart, and as can be seen after the fifth dose of IV methylprednisolone, the vision improved to 20/40 with color vision being 21 out of 23 Ishihara chart. So at the time of discharge after six days, a resolving retinitis lesion macular edema SRF can be seen correlating with the OCT findings. So reviewing the literature, the first article is a review article of published in Indian Journal of Ophthalmology that discussed about the post-febrile retinitis and the specific microbial investigation, while the second is a retrospective study in the RP Center AIMS, which discussed 19 eyes of 13 individual and discussed about OCT features and various treatment protocols. So final follow-up visit, the patient recovered almost the full vision, and the clinical implication is of my case is that the retinitis post-febrile illness with significant or out of proportional visual loss always suspect retrobulbar optic neuritis that can be both unilateral and bilateral, can be confirmed on MRI, and the pulse steroid can salvage the vision in post-fever retinitis optic neuritis given with the cover of antimicrobial therapy. Thank you.
Thank you, Dr. Akshat. Thank you, Dr. Akshat. In this part of India, we also came across this type of cases, not very frequently, but sometimes. But over and above, the exact etiopathogenesis is obscure. We also follow the same sort of treatment regime and got beautiful visual outcome. couple of months or so.
So you showed us OCT of the retina where there were exudates. What about OCT macula? Was it normal?
OCT macula was also there. It has the subretinal, the neurosensory detachment and subretinal fluid mainly.
Okay.
It because of the retinitis going on along with optic neuritis.
Okay. Because the vision you were, so I must congratulate you and the consultants who were dealing. It was a nice case and it has been well documented also. Angiography images were also very nice. Only thing was, yes, you should raise a suspicion when you do not correlate the vision with the findings you are seeing. Even if there is a cuff of fluid in the macula, the vision cannot be finger counting or 1 by 60 or PL positive. You need to think that it might be something beyond. So always keep your mind open. Don't just go forward with the treatment. Okay, it might be just because of the retinal pathology. Sometimes, yes, optic nerve pathology, as in this case, can be associated along with the same. So
Also the RAPD.
yes, RAPD component was also there, but sometimes in the initial stages they can be just grade 1 RAPD. It might be very subtle and you might just miss it in a heavy OPD. So just correlate the vision with whatever you are seeing.